Thanks, Christina. And hi, everyone. I also had the same problem. I couldn't turn off my video. So I'm just going to speak over the mic. I'm the medical advisor for HNF. And so it's been honor to host a series of very esteemed speakers. And all of them were helped coordinated by the speaker for today, Dr. Han Yee, who is the head of department of Tan Tock Seng Palliative Medicine. So I'd like to also thank our previous speaker, Dr. Lee Chung Seng, Dr. Ao Chia Hui, Dr. Chiam Ziyan. They all spoke on general principles of palliative care for the frail elders, on advanced cardiac and renal diseases palliation, and palliative care for advanced respiratory diseases, including COVID-19. And today, to close it, is a topic which is close to my heart, and I think you will find it very practical, about critical communication. I mean, don't we all know communication is the basis of trust, and trust is the basis of care. And also he'll be sharing on ethical dilemmas, and he is not stranger to this. In fact, he, as far as I know, I mean, I'm also his good friend. He specialized in ethical issues in healthcare settings. And so he is yeah, I'm trying to get to the screen where I like to give a short description of his background. Dr. Neo is a senior consultant and head of the Department of Palliative Medicine at Tan Tock Seng Hospital. He's a chairperson for the Clinical Ethics Committee at this hospital, as well as an adjunct assistant professor at Lee Kong Chian School of Medicine, where he teaches clinical ethics and palliative medicine modules. So so before I hand over the mic to Han Yee, also just like to share for those who are here that the previous sessions can also be found on our YouTube channel, HNF YouTube channel. You can get the link through the QR code on the poster for publicity. And you can see my background here. I'm actually teaching a class of gerontologists, and I invited all of them to participate in this webinar because communication, end-of-life care, ethics are all bread and butter issues for gerontologists practicing. So with that, I'd like to hand over the session to Dr. Han Yee. So we have some time, maybe 10 minutes or so for Q&A, but let's see, maybe let's hear from Han Yee first. Yeah, thanks, Han Yee.
Yeah, thanks, Dr. Tiong. Thanks, Wai Chong, for the kind introduction. Let me try to share screen now. Give me a short while. Looks like I'm the one also having a little bit of technical difficulties now. Okay. Okay. Just give me a short while. Okay. Now, basically, as what Dr. Wai Chong has shared, I'm a geriatrician by primary training, followed by a palliative care consultant at Tan Tock Seng Hospital. My other training is in clinical ethics, and that's really a 3-month HNDP in Hawaii. It wasn't that great a Hawaii HNDP experience in that I didn't spend a lot of time by the beach and all that, which I regretted. But what happened really is that the professor there, and some of you all might know him, Professor S.Y. Tan, a very esteemed endocrinologist, as well as a very esteemed professor in clinical ethics, actually mentored me, and it was a very rigorous kind of a process, a lot of dealings with the law and how the US may look at certain things this way and how we may view it differently in Singapore itself. Just give me 1 minute. Okay. Still seems to be some problems there. Just give me 1 minute. Okay. So I'll be speaking on 2 things, that of clinical communication, as well as Okay, hi, so sorry about it. Some technical issues on my end, a bit unusual. Okay. Let me try this again. Okay, right, I think it's working fine now. Okay, good, yeah. Right, so I'll be speaking on two different topics and it covers quite a bit of breadth and depth. So I'll go for more breadth and depth today. Actually, there are courses that's being run by PALC, the Palliative Care Center for Excellence in Research and Education, that everyone can Google. And many of the topics that we'll cover today will actually be more detailedly shared at the clear course that you can look for at the PALC website. So I'm going to go with a few case vignettes to first discuss some of the common ethical problems we see in palliative care, followed by some of the communication strategies that we have devised over the past few years. Right? I've chosen the cases more in the ICU setting because it is in this setting whereby you see a lot of emotions play out, a lot of different voices that's trying to be heard, the family, the patient, the doctors, the distant family member, the overseas returning daughter, a lot of these stereotypical pictures that leads to multiple points of tension. Right? So all these cases that I'm sharing today is actually de-identified, which means that you should not be able to recognize the patients from the description. Right? So this is a story of a 70-year-old Sikh lady, newly diagnosed with a neuromuscular disorder that is actually treatable and reversible. Right? Was newly diagnosed but never treated. And because of this neuromuscular weakness, she wasn't able to breathe well. She contracted a pneumonia and she had to go to ICU to receive mechanical ventilation. So she was on an endotracheal tube as well as a ventilator. She was a very feisty lady, so she insisted to remove the tube at all costs. So she can't speak because there's a breathing tube down her throat, but she would gesture very vehemently. It's just short of extubating herself by pulling the tube out. And the strange thing is, her decision was supported by her immediate family members, although we explained comprehensively that this is a very treatable illness, right? We may not be able to cure the illness, but it's definitely something that we are able to control, and the patient can go back to functionally almost a normal life, right? At the same time, also, a close friend of hers came to the hospital and also gave an account that she had a previous conversation with the patient, where the patient mentioned that she doesn't need to be artificially ventilated in the event of a critical illness. She would rather pass away if she were to face a terminal illness, because she finds that such invasive management is uncomfortable and she doesn't feel that there is more milestones to complete in her life. Right. So in such a setting, what should we do? Because the doctors are pushing to treat the neuromuscular weakness and to take the patient off the machine so that the patient can live for potentially decades. But the patient herself doesn't want these machines and treatment. Family members supports the patient's decision. And there's a friend who gives an account that there was an antecedent verbalization that she said she wouldn't have wanted this anyway. So this particular case vignette will cover quite a few topics in clinical ethics. So we'll go through some of the broad principles first before we go to analyze this case. So we'll first talk about informed consent and mental capacity, right? Of course, now we are not talking about so much about the consent for procedure, but we are talking more about an informed refusal of continuation of the mechanical ventilation. So when we talk about valid consent or informed consent, there are usually three components that needs to be fulfilled. First of all, we have to prove that the patient has got mental capacity, or rather, the patient must possess mental capacity as the first step. The second step would be that we have to disclose sufficient material information for the patient then to make a reasonable decision. And her decision needs to be freed from external excessive influences, what we call coercion. So these three components need to be there for there to be a valid informed consent or an informed refusal. So you can imagine in this particular case, the first thing we have to ask ourselves is, does the patient possess mental capacity? She's elderly, she's unwell, she's an infection, she's in the ICU, she can't speak. There's a good chance that she may be delirious. So how certain are we that her decision to want to remove the tube is not motivated by an organic illness? And if given a clearer state of mind, she could have chosen perhaps a more aggressive nature of care. right? Secondly, could she understand all the information we give her? Are we giving her all the information that she needed to make a decision? And thirdly, are there other coercive forces at work? Are there other agendas from not so kind family members, perhaps, that's going after her property and assets? So these are the things that we need to talk about. So in Singapore, this particular area of mental capacity and informed consent is very well written in our Mental Capacity Act, and it's something that we should all really read through, right? Every adult person is assumed to have mental capacity unless proven otherwise, right? In order for you to contest whether a person has got an impaired capacity, there needs to be some form of organic or psychiatric illness, right? Which means it can be, for example, an organic illness like a brain tumor or stroke, or it can be a psychiatric illness such as a major depression, right? These illnesses must then be proven to be significant enough to impair the person's judgment. And then how do we decide whether it's that bad that a person can't judge, right? We use 4 standards to sort of analyze. Is the patient able to understand the implications of the illness and the options? Is the patient at least able to retain these informations over a reasonable amount of time for the patient to then use this information and weigh the different options available, think through the benefits and risks of various treatment, and then finally communicate consistently and clearly to the healthcare providers about what he or she wants, right? So these are the methodological way in which we look into mental capacity and decide whether a person has a valid decision-making capacity. Now, decision-making capacity is also time-specific and task-specific. A person, especially an older person, may be delirious because of an acute illness, but after the acute illness resides, the patient may then possess mental capacity again, right? So while a person may not have capacity at that time point whereby you sort of assess her, if given treatment, her capacity may return and you have to then seek her opinion again. Are there, for example, very bad emotional or cognitive fluctuations? Is the patient very emotionally distressed at that point in time, such that it impairs her judgment, and that can be reversed with counseling or with reassurance, right? So that's why decision-making capacity can be time-specific and should be reviewed in a timely manner. It is also task-specific, right? An older person with mild dementia perhaps, can make a decision about who she wants to live with, which doctor she may want to see, which daughter or son she wants to allow to visit, but she may not have the ability to make complex decisions, such as whether to go for chemotherapy, to go for a certain surgery over another, right? So that is something that we have to look at as well. Decision-making capacity is time-specific and task-specific. And that is why we have to consider for a unique patient, this particular individual, with her mental faculties at this point in time, would she be able to then make a decision based on the complexity of the task given to her? And because there is this dynamic balance, between the complexity and gravity of the task, as well as the cognition of the individual, there is this concept of a sliding scale. The doctors and nurses amongst us may understand it somewhat like the sliding scale we use in insulin and diabetes control, right? So when a person's task that's asked of them to perform, if this task is something that's very complex, the consequences are very grave, it is life and death, major morbidity, then we better make sure that the mental capacity threshold is held at a very high standard. Whereas if this decision that the patient needs to make is something of less of a consequence, something that's not so much of life and death, something that doesn't cause her much harm or morbidity, then we can probably lower that threshold of testing capacity at sort of a lower threshold. Right? So there's this sliding scale that we look at in terms of assessing the patient's ability to make decisions. Now, having said that, if we are certain that a person has got mental capacity, the next question we have to ask ourselves is, have we told the patient sufficient information so that she can make a reasonable decision compared to, a peer? Right? Under the Singapore Medical Council, the ethical code and ethical guideline, it is very clear that we must inform the patient of all material risks and alternatives, right? It is also captured under our legal system, our healthcare laws. So some of us may be familiar with the modified Montgomery test, which was actually a case that went to court between the SGH, very eminent hepatobiliary surgeon, and a Malaysian datuk, a businessman, right? And the SGH surgeon won the case for that matter, right? But it sort of gave the opportunity for the Chief Justice to introduce this modified Montgomery test, a test that looks at whether the doctor has given sufficient information to the patient. So the modified Montgomery test has got two standards that a doctor needs to fulfill. First of all, he must tell an average person all these things: the diagnosis, the likely prognosis of the condition, the life expectancy, what is the procedure that he's advocating, what are the alternatives, and what are the strengths and complications related to each treatment option. Right? So this pertains to an average person, what we call the reasonable patient rule. Now, the modified Montgomery test also has a second standard, what we call the subjective standard, or the particular patient rule. So this is not about an average person. This is talking about the person that's sitting in front of you, right? So if this particular person has told the doctor that there are certain concerns specific to him or her that he's very worried about. For example, a violinist would say that, if I want to go for a simple carpal tunnel surgery, would the surgery affect the ability for me to use the bow and the violin? If he tells the doctor that, the doctor then needs to go into more details about the likely complications of surgery, even if these complications are rare, right? Because it has major implications to the violinist's professional growth and career development. So this pertains to the particular patient. So that is why, in order for us to fulfill this rule, we have to be quite careful about what the patient told us, what we have documented in the notes, and address these concerns in a relevant manner. However, we are not required to dig out all the idiosyncrasies if the patient didn't tell us and volunteer this information. Usually, as a doctor, we'll just ask them, what is your favorite leisure activity? What is your profession? So that we can make a decision about what's relevant information that's important to this particular patient. Okay, so I would say that at this point, I'll let you know about what happened to this 70-year-old sick lady, right? So it's very strange because we can't really speak to her. She was very emotionally charged and distressed, right? We tried to communicate to her by gesturing, by writing. We asked her to write with a pen on a word pad because she's well educated, but the handwriting was almost illegible. She was writing repeated numbers that doesn't make any coherent sense to us, right? But it was quite clear that she wants the tube removed, but she couldn't quite tell us that you have to remove it because I'm very uncomfortable and I would rather die than to be kept alive like this, right? So she couldn't quite demonstrate that she could understand the implications of removing the ventilator, nor the implications that follows, right? And with that, we sort of asked the family members, is she behaving in a manner that's similar to, her usual self? And the family members agreed that this is not her usual self. She's definitely more temperamental than her usual self. And that's why we diagnosed her that this is probably a delirium due to an organic illness. And therefore, her capacity is in question. As I've mentioned, because the consequences of removing the tube may be death, we have to hold that threshold of mental capacity at much higher standard. And therefore, we certify that she does not have capacity to make such a decision, right? But that does not then mean that because the patient does not have capacity, we will then move on to override her, right? We still have to look into what her past wishes, what she has said before to her family members. Does she have any advance directive? Does she have any advanced care plans? And that's when we spoke to the family and the friend, right, about what they knew about her personality, what she has told them before, right? Now, before I fill in the details about what the family shared with us, I'll just go into a bit of broad principles again about the advanced medical directive, the lasting power of attorney, and the advanced care plan. So the AND, LPA, and ACP in short, right? So many of the lay public is mixed up about these three documents. And oftentimes when they ask healthcare professionals, we also need to think quite a while before we can give them the answers that the lay public wants. The lay public often thinks that if I put up an advanced medical directive, an AMD, then if I were to have a serious illness, the doctor shouldn't be sending me to ICU, doing CPR on me, or using life support machine to prolong my life. But in truth, the AMD is hardly used in the hospital setting for a few reasons, right? Operational issues aside, it can only be invoked if a person is imminently dying. And the Act itself is stated very clearly, right, that it can only be invoked if death would be imminent, regardless whether we apply ICU level, extraordinarily life-sustaining measures to keep them alive. So you would then find this particular law very strange. If a doctor judges that whether or not I send the patient to ICU, the patient will soon die anyway, then why would he even offer to resuscitate a patient or put the patient through invasive and uncomfortable procedures? Now, I'll tell you that the AMD was enacted at a time more than 20 years ago when the society is very conservative. And the general public are worried that the government may then start removing the ventilator from old people in the ICU in order to, avail the bed spaces for younger patients at the A&E. So because of that very conservative culture at that time, it was enacted in a manner that's very, very cautious, that limits its application. Now, in addition, operationally, you can only, you cannot ask whether a person has got AMD from a family member. The family member must ask you voluntarily. And then you must go and clarify with the registrar, the ministry's official, whether or not a person's AMD is registered, nationally, and that can only be done during office hours. And many a times resuscitation is a matter of medical emergency, and we don't have the time to actually check the AMD with a registrar. So because of all these operational and legal constraints, the AMD is hardly being used in Singapore, and is very much something that we will not use in our routine practice, right? But however, a person having an AMD does illustrate a certain preference that he or she may have at that point in time, whereby she actually did up an AMD document, right? Now, the second document, called the lasting power of attorney, is also a legal document. So family members and patients may then think that we put this document up and then we sort of appoint a surrogate or a representative, what we call a donee, right? The donee can then make a decision with regards to all these ICU life support measures for me. Actually, again, the lasting power of attorney was actually created not so much for medical emergencies. It was set up more for personal welfare, property, and assets. Right? So there was only a very small component under personal welfare that deals with medical care, right? And in fact, later on we'll go into detail. The donee that you sort of assign is specifically excluded from making major treatment decisions for you. And this includes specifically the use of ICU level life support treatment. So therefore, the donee and lasting power of attorney can perhaps decide on simpler things, like which hospital to go to, which doctor to see, simple medications, right? Perhaps who should visit you in the ward and who shouldn't, but they cannot make decisions with regards to serious illnesses. And the last document is the advanced care plan, which many of us are familiar with. This is not a legal document, but it does carry legal weight. It carries enough legal weight as any other clinical document that the doctor writes into his medical record, be it physically or electronically. If something goes wrong, the court will ask for these documents to be available for examination in court, and those documentation would then serve as the basis for the court to jurisdict whether a doctor has malpractice. Right? The ACP is actually very much an open-ended conversation that talks about what is the acceptable quality of life of a person, beyond which the person would feel that using life support would not be worthwhile. So some of our older persons may say that if one day, I become I have a severe dementia such that I can't self-care, I can't recognize my family members, then please don't try to keep me alive, right? But this is also very subjective. Other seniors would then say that, if let's say, I still have some degree of ability to communicate, but I can't self-care, I need people to help me to go to the toilet, to pass motions and maintain my hygiene, then if I lose my capacity one day, don't try. So it is very subjective, this idea about what is worthwhile. And people's views may change, as you can expect. So we have patients whereby, they first made an ACP stating a more conservative role, if they deteriorate, and then something social happened within the family. So for example, the daughter becomes pregnant with the first grandchild, and they said, maybe I want to change my ACP plan. I want to see my first grandchild being born. and then the ACP plan needs to be changed. So all these documents actually are also time sensitive and also needs to be reviewed whenever there are changes to the medical condition, the patient's social context, or if we suspect the patient may have a change in preferences. So what happens, right? What happened to this sick lady? So we found out from the family members that she's someone that is sort of a matriarch within the family, meaning she's the dominant decision maker in the family. The husband, the children, all must listen to her. She's someone that values autonomy and dignity. She finds that she has completed her life and there's no other major things that she needs to do with her life. She's ready to go to meet her maker any point in time. And therefore, she has told the family members repeatedly that she doesn't need to be kept alive. When things go wrong, it's time. She wouldn't want to be put through procedures that make her feel indignified or uncomfortable. And because this consistent narrative was elicited from different family members and from her close friends, we reasonably believe that this is truly her background personality. And therefore, based on that, we decided to respect her wishes, right? And remove the ventilator, right? But thankfully, because there was some sufficient lead time for us to treat the neuromuscular disease, right? We did manage to suppress the disease to a certain extent and allow her to survive after the extubation. So it ends up to be a pretty good story, a pretty good ending, right? And I'm pretty certain that if we were to ask her a week later or 2 weeks later after the ICU admission, she will probably tell us she can't remember what we asked her in the ICU, which is not something that's infrequently seen when a person is delirious, right? So I think that's quite a complex case, but it illustrates a few key components of ethics, that we deal with at the end of life, right? I know there may be questions amongst the audience, but we'll save the questions for the Q&A session later on, right? Now, another common question that we get asked very frequently by family members are that, if my so-and-so has got an advanced cancer, can you not tell him or her about the illness, how severe it is, how much time he or she is left with? Can you just continue the treatment anyway, so that we don't frighten her, we don't get her depressed or lose the willpower to live, right? Just get on with it. Other family members may be belligerent. They may then tell us, if you ever dare to tell my father or mother that she has got a terminal cancer, I will sue you, right? And then that becomes very ugly in a healthcare setting. And that's when the doctor or nurse or any healthcare professional that takes care of the patient may be a bit uncertain about whether or not the law would be on our side or our own organizations would be on our side if we were to what we call break collusion to the patient. Now, remember what I mentioned about information disclosure. So any treatment, especially big treatment, major treatment that we give to our patients, we must make sure that our patients receive the material information needed, to make a reasonable decision. So if we purposely hold back a person, from telling a person what is needed, to make a decision about surgery or chemotherapy, like this big net whereby a person was newly diagnosed with a pancreatic cancer, and the treatment is a major surgery that removes part of the stomach, part of the small intestine, the whole of the pancreas, and the bile duct, and then post-op still need to receive chemotherapy, then we have gone against the law, right? We have gone against both the professional requirement under our SMC-CG as well as the law, right? And on the other hand, the family members are suing us, if let's say we make the patient depressed, or if the person turns suicidal, or the person is perceived to have lost hope and lost the motivation to live, then how, then myself don't be doctor, nurse, I'm very gung ho, So what are we supposed to do? Actually, if actually we are familiar with our professional guidelines and the law, we know that actually they are all on our side. Again, referring back to the SMC-ECG, and this will be updated pretty soon, by the way, right? It is quite clear that the patient autonomy is a fundamental principle in healthcare, and their decision must be respected. In order for us to respect a person's autonomy, then the person possessive of capacity must receive the information needed to make a decision. So that's very clear. If we try to deceive the patient on any aspect of their diagnosis or management, then we went against our professional code of conduct, right? And if family members insist that you withhold information from the patient, the guidelines specifically say this, you must not do so unless you assess that the patient will react in an extreme manner, which would cause harm. Now, this is not something that we can lightly invoke, right? We would have to prove that the person, for example, is having a major depression. Usually a psychiatrist needs to make a diagnosis, or the patient has a history of self-harm and suicide and such like, in order for us to then meet this criteria. If you do not meet this criteria and we withhold this information from them, and the patient suffers a consequence, a complication from the treatment, the patient can sue us. The patient can say that, how can you, not tell me about this major, complication that is that's quite important for me to know, and how are you going to prove that I am going to be suicidal or depressed? So the healthcare professional must prove to the court, must prove to the judge that there are valid reasons for me to suspect that the patient may self-harm. So in order for us to really withhold information from a patient, we must really prove this point in a very valid manner. Now, having said so, there are 3 exceptions whereby the law allows us to withhold information from the patient, right? Number 1, okay, for example, in many of our seniors, they may say that, I'm not so well educated, I may not be English speaking, my son is better educated, or my daughter is better educated, and I would want him or her to make a decision for me. So if a patient voluntarily says that, I want to waive off my autonomy and allow a family member to make a decision for me, then he or she has waived off this autonomy, and then we can go on to discuss with the representative. Secondly, if a person is in a medical emergency, for example, in the ED or in the ICU, and there's not enough time to discuss with the patient the full complexity of the procedures, right? And under such medical emergency setting, we do not need to take informed consent. We can proceed in the patient's best interest. Thirdly, that would be the therapeutic privilege, right? This is where there's a bit of a lack of clarity. Yeah? This particular slide comes from the modified Montgomery test that I mentioned earlier on. So the Chief Justice actually gave these few examples that need to be interpreted when the next case goes to court. So for example, she said that, if the patient has a major anxiety, a panic attack, and can't make decisions, this one easier, we can get a psychiatrist to prove that. The court also says certain geriatric patients easily frightened out of having even relatively safe treatment that can drastically improve their quality of life, then you need not tell them the full implications of treatment. So this is a bit of a gray area that I think we shouldn't test the limits. You don't want to be the test case going to court to speak to Chief Justice, right? Okay. And then, of course, if let's say, the person has an impaired state of mind, intellectual disability, or educational level just cannot quite understand, you have to prove that. You have to prove that, you have really expended all means to explain to this particular person, no matter how humble a background he or she comes from, before you can then say safely that I've tried, but I couldn't. Right? So these are the only 3 settings whereby you can withhold information from a patient, particularly with regards to treatment with major consequences. If not, we cannot, corroborate with the family's request for collusion, because we'll definitely get into trouble with our professional body as well as the court. So that is why, does it then mean that we can then quote verbatim these slides that I mentioned earlier on to the family member and say that, can you refer to section so-and-so of our SMC ethical code and ethical guideline, and please look at the judgment, that talks about modified Montgomery test, paragraph what, almost like a lawyer fashion. You can read it yourself, and then that will tell you that I have every right to tell your father and mother. Now, usually, of course, we will not do that, because when you do that, you quote the law, you quote guidelines as a final line of defense. That's where you truly put yourself in a confrontational mode with family members. Now, we always want to work on a corroborative front. We always want the family members to understand that we are coming in, in the best interest of the patients. The conflict arises because we see things in a different perspective, with a different lens, but the intention is the same. We want the best for your father or mother. So we always try not to use the law or the professional guidelines as a solution. Communication is always the key strategy to try to resolve such conflicts. And we'll talk more about these strategies later on. Okay. Now, in the interest of time, I'm going to jump a bit quicker into medical futility and the authority of the family caregiver. Now, again, I de-identified this particular patient, but it gave some hospital staff quite a bit of grief and trauma. So this is a 50-year-old Eurasian man. who suffered an aneurysmal bleed. An aneurysm is almost like a balloon in one of your major blood vessels in the brain, and it burst. In this Eurasian man's case, it burst. It led to severe brain injury. At the A&E, he was quickly transported to the theater, whereby they did a surgery to relieve the pressure from the brain and to evacuate the blood clot. But despite the best efforts, the brain injury was irreversible. The patient stayed a very long time in the ICU, developed multiple complications that made his blood pressure low, and as a result, the brain suffered further injury, to the point that we find that the patient needed a ventilator to breathe at all times. Right? Once we reduce the breathing rate set by the ventilator, we find that the patient doesn't seem to be able to initiate breathing on his or her own. So this is a time whereby we start to suspect that there's major damage to the brainstem, almost like the CPU of a computer system. So once the brainstem, the CPU gets damaged, right, it also means that if we remove the ventilator, the brainstem will not be able to support life. Support life in terms of breathing, maintaining blood pressure or heartbeat, and that's when we say a patient may be brain dead. Now, there is a very extensive and cautious process for a doctor in the hospital to certify brain death, right? Of course, in such a setting, we need to go ahead because we shouldn't be, ventilating a person who is by legal criteria dead and by medical criteria will never be able to recover cognitively. Right? The person would, be so damaged that he would not be able to make any meaningful interaction with the environment of sustained life. Right? However, the partner of the patient was very belligerent for reasons that I will not go into detail. Again, he threatened to sue. Again, he threatened to go to the police. In fact, he made a police report against the hospital because we said that we need to proceed with the brain death certification. And if the person is certified to be brain dead, then we have to remove life support because it will not be appropriate to sustain life for a person who is dead, legally dead, right? And he refused. And of course, we tried all means to mitigate and to communicate and to engage, but all strategies failed to engage this particular partner. And we had to go ahead with brain death certification with security guards in the ward to prevent him from stopping the patient from going down for a special scan of the brain, right? And of course, after the patient went through certification, the patient was certified to be brain dead, and we have to remove the ventilator. Now, this is a very special situation whereby everything we tried has failed. Every counseling, every way to soften the impact has failed to try to engage this partner. And trust me, we tried really very hard. And after the patient passed away, the partner continued to make police report, continued to try to engage lawyers to sue us. And of course, no lawyer wants to take up his case because the person is certified brain dead. But the person, the partner is quite an intelligent chap. He tried to write in to complain and copied how lawyers write their report in a very legal sort of setting, hoping that we would give in and perhaps give remuneration and all that. Of course, we know, as long as we know our clinical grounds, we stand firm on our clinical judgment, we know the professional guidelines and the law, then there's nothing that we need to worry about. So this patient continued to complain against us, and police report generated quite a bit of administrative work, but no, we were not worried about any legal repercussions. So then this brings in the question of what is medical futility, right? So medical futility, now first of all, I must caution that we should not use the word futile anymore. When you use the word futile, it brings on a dimension that is very emotionally charged in family members. You're almost telling them that your family member, your loved one, is not worth treating compared to maybe a younger person or someone else that may have a better chance of surviving if given the ICU bed. Right? So that's why we do not use the word futile. We said that the treatment, the life support is inappropriate or appropriate. Inappropriate in the sense that the harm will outweigh the benefits, or that there's no objective benefit to come up from that intervention. So under the American Medical Association ethic codes, not only in Singapore, but quoting an American source, now clinicians are not obliged to deliver care that in their best professional judgment will not have a reasonable chance of benefiting their patients. And patients should not be given treatment simply because they unilaterally demand them. So for example, if a person has got advanced cancer and the chemotherapy is too toxic for him to receive, to tolerate, and he demands chemotherapy. Does a doctor need to continue to give chemotherapy to a patient just because he demands? Of course not, right? We are doctors and healthcare professionals with a conscience. We can't deliver a toxic treatment, make the patient go through side effect, knowing that there's a greater probability that the patient will still die and die in a horrible manner. So if a treatment is inappropriate, we are not professionally obliged to provide them. Now, this is similarly captured in our ethical code and ethical guideline, written in a similar fashion, but not entirely identical. You are not obliged to provide treatment that you deem inappropriate, non-beneficial, or even harmful, right? However, we also must be careful when we talk about futility, or what we should be now referring to as inappropriate care, because some of the younger doctors in the hospital may then speak to family members in an inappropriate manner, in a wrong manner. Of course, this is very infrequent already after our training over the past few years. They would sometimes wrongly tell family members that, your elderly father or mother shouldn't be going to ICU because it is unlikely that he or she will survive, and the bed should be safe for someone else. Now, that is clearly wrong. Like I mentioned, you put you on confrontational mode with family members and all hell break loose. There's mistrust and there's no way you can have a good resolution, right? Now, in order to sort of look at this problem, we must be quite clear of two different constructs, right? In futility, or what we call medical inappropriacy, we are dealing with one unique individual, whereby that specific treatment will not confer overall benefit. The cost and the resource put in is not consequential to your analysis. We are basically saying that this treatment, be it expensive or not expensive, will not bring about an objective overall benefit. It does not deal with distributive justice. It is specific to that patient in front of you at that time point, right? Whereas rationing, which is what the younger doctor is talking about, is dealt with at a very macroscopic level. So for example, when the pandemic first broke out and we have got limited vaccines, certain countries may need to decide who gets the vaccine, or certain countries need to decide who gets the ventilator. So I will also share with you that almost all developed countries will have their own rationing guidelines. Should there be a major pandemic wave such that our ICU cannot handle and we don't have enough ventilators to go around. Now, it never happened in Singapore, and I do not think that it will ever happen now, right? But rationing is done at a very macroscopic system level, whereby a panel of experts are called in to formulate a guideline and a criteria to decide who gets what. This criteria will be transparently applied to every individual that needs that scarce, limited resource, right? So in this case, rationing deals with a scarce and limited resource that may be very costly, but they will always be beneficial to these patients that are being considered, right? But we are not giving some, but we're giving others based on a set of predetermined clinical criteria. Often, in a setting whereby resource is limited, you will go to patients who would most benefit from this limited resource, right? So never tell the family members that, no, your family member don't deserve this treatment because someone else should deserve it better, right? Because first of all, it's ethically wrong. The reasoning is not sound. And secondly, it brings you on a confrontational, emotional journey that will not bring resolution to the problem. Now, also, as I mentioned, in Singapore and in Singapore only, right? In Singapore only, under our Mental Capacity Act, even if the patient has already sort of designated a representative to make decisions for him or her, even if there's such a legally authorized person, this donee under the lasting power of attorney is excluded specifically under the law to make decisions about life-sustaining treatment or any treatment, right, which a healthcare professional reasonably believes is necessary to prevent a serious deterioration in the patient's condition. So when the parliament sort of convened and one of the speakers sort of asked, why should this be the case? Overseas, if you have got an advanced directive, you have got a designated legal representative. Many of these countries like UK and US, if you specifically state that this person can make such a decision for me, then the doctor must abide by the decision of the designated spokesperson, and that was when I think one of our minister then replied to say that just to make sure that the family member or the donee is not after the person's money, something to that extent. So it wasn't due to some complex legal thing. It was just structured in a very cultural, sensitive manner, something very specific to Singapore. And for that matter, I do not know of any other country that specifically state that a legally designated donee also cannot make such decisions. So you can see that actually in Singapore, the law actually slants very much towards the healthcare professional. If the healthcare professional makes a decision that he can justify in the patient's best interest, right? And there will be no specific family member, be it a father, a mother, a wife, a spouse, a partner, a son or daughter. There will be no one in this whole line who will be prioritized as the person who will have to shoulder that final decision. That final legal decision about whether to continue treatment, to give treatment, or to withdraw treatment comes from the doctor when a person loses mental capacity. But under Mental Capacity Act, the healthcare professional, usually the doctor in charge, is legally obliged to speak to any significant person, any significant family member, any significant donee of the lasting power of attorney to try to elicit what the patient might have wanted or what the patient has said before, that we can extrapolate to know what the patient probably would want if he or she could speak to us. So with regards to treatment at the end of life, it often comes into conflict with grieving family members, especially when the injury to the body or to the brain is something that's very steep, fast, unexpected, like a road traffic accident, like a sudden hemorrhagic bleed in the brain. Because of the suddenness of the etiology or the very complex psychosocial dynamics that happens in the background, the guilt complexes and all that, family members may be very aggrieved and then transfer their emotions to healthcare professionals who are trying their best to help the patient. And then there's all these arguments about going to court, I'll sue you and all that should be resolved on a more humanistic fashion. But if truly there are such contests and such insistence, we also need to know enough of our own ethical code and laws to be able to stand firmly on what is right. Okay. Now, one of those issues here is also that often when palliative care is called in, it is wrongly perceived as euthanasia or physician-assisted suicide, right? And family members may then accuse the healthcare provider of trying to euthanize a person. It doesn't help when a Chinese translation of euthanasia is 安乐死 or to die peacefully, right? Which is what palliative care wants to achieve, for a person to die peacefully. But we do not try to make a person die peacefully by making the person die faster, right? We make the person peaceful and comfortable and allow the natural disease to run its own course. So that is in line with palliative care. Now, I'll just introduce to you this broad framework of what we call medically assisted dying. So under this broad umbrella of medically assisted dying, okay, there is euthanasia and there's physician-assisted suicide. Now, euthanasia can be voluntary, involuntary, or non-voluntary. So a person can say, please euthanize me. So there's this organization in Sweden whereby you go to, you register, and then after that, they will perform euthanasia for you for consenting adult, right? There can also be involuntary euthanasia, whereby many years ago in the US, there was this Dr. Death, you can Google Dr. Death, whereby he used his own device machine to deliver a toxic lethal concoction to kill patients in the nursing home that he views that life is not worthwhile sustaining. So these patients with advanced dementia in the nursing home do not possess capacity and therefore cannot say want or don't want to be euthanized. So in this setting, this is involuntary euthanasia, right? There can be non-voluntary euthanasia whereby, the person may not have the intellect ability, for example, in severe Down syndrome, intellectual disability, they cannot understand what are the implications, and then the procedure is carried out without consent, right? So this is non-voluntary. Now, euthanasia is a bit different from physician-assisted suicide. Physician-assisted suicide is a procedure whereby, the intention is still to hasten death, is to let death occur faster so that the person does not need to suffer a longer period of time, right? But in this case, the doctor, usually the doctor, would prescribe a lethal prescription. The prescription is then brought to the pharmacy. The patient or the carer then buys the drug and administers the drug. So the doctor becomes an indirect player in this whole temporal sequence of causality, right? But the intention remains the same, which is to prematurely end life, hoping to stop further suffering, right? And the end consequence is death. Now in Singapore, euthanasia and physician-assisted suicide are both legally the same as murder, right? If you look at it, murder, you have a murderer with the intention to kill, to hasten death, right? And then there's an act of killing, be it by stabbing, by giving poison, by ramming a car into a person, and then the person dies, right? So you find that euthanasia and physician-assisted suicide fulfills all legal criteria for murder based on this table that I'm showing you. But in palliative care, or when we need to withdraw inappropriate or futile treatment, it is very different. The doctor's or the nurse's intention is not to kill the patient. When we need to withdraw a non-beneficial treatment, what we are thinking is that if there is a solution, if we can help the patient live longer and better, we want the patient to live longer and better. But no, treatment will only prolong suffering and it will not bring about objective benefit. And therefore, we withdraw an artificial management that's sustaining life to allow natural death, right? So the agent that causes death is not a lethal injection, but the disease that goes on to progress such that the life cannot be sustained by the body. The end consequence of all these is death, but the intention is very different, right? The agent that caused death is also very different. And therefore, it differs both in terms of intentionality, it differs in terms of causality, right? And therefore, then legally it's looked at very differently. Now, I know, of course, that, like I mentioned, when we talk about, always talk about ethics and law, there's always this contention between the doctor and the lawyer. And you would also know that Tan Tock Seng is having a court case now, right? Which I'm pretty confident that will be okay, right? But because we are always on this conflicting end when they try to, threaten us with lawsuits and all that, we have to give a lot more consideration to complex treatment decisions, right? And because of that, we go to the next section about clinical communication. Now, there are many acronyms that I'm going to use today, but you don't have to remember them offhand, right? Because these slides will be available to you, and this will be also something that you can look at on YouTube later on, as I understand, right? But this framework is developed by the department under the auspice of PALC. So again, you can look for the course for it when it's developed. So this 4E framework of complex clinical communication by principle deals with these three things, right? We want to convey information in a clear manner to family members. We also want to clearly understand and hear what their factual concerns are. We want to emotively and humanistically engage the patient and family member so that they feel touched by our intention to help and they trust us. The trust is the gut that we are seeing here in the picture. Ultimately, the information that you give to the patient or you receive from the patient, the emotional engagement you have with the patient all boils down to one thing. You want them to trust you, to go ahead with a decision that everyone is comfortable with. So I think that's the bottom line for clinical communication, really, to build trust so that we can go ahead in a manner that's in the best interest of the patient. Okay, so this is just a few broad principles. The brain, of course, is cognitive factual processes. The heart deals with feelings, deals with intuition, deals with emotions. And the gut feel, the intuitive, instinctive feel that you can put a finger on and say that I trust this doctor or I trust this nurse, right? Okay, so with this, I'll go into details about this framework, what we call the 4 E's. Now, the 4 E's is divided into 2 quadrants, right? The patient or the family member wants to feel known and understood. This is very important. The healthcare professional wants the family member or the patient to know and understand all the huge volume of medical information we want to convey across, right? So one deals with the left side of the brain, one deals with the right side of the brain. And any individual is made up of both the cognitive part as well as the emotive part. And this particular framework deals with both hemispheres of the brain, right? But if there's anything at all in this kind of very complex and challenging clinical communication, remember always that feelings always come first. When feelings are reassured, when there's rapport, then deliver the facts and everything will move much, much smoother. Problems happens when healthcare professionals provide the facts without addressing the feelings. And that's when mistrust starts to breed and then everything starts to fall apart. So if you remember the 2 hemispheres that I talked about, the right side talks about feelings, the left side talks about facts, right? So if we divide now the quadrant into the circle into 4 quadrants, empathize and engage deals with feeling, establish and empower deals with facts. Okay, so just remember that broadly first. Now, for each of these quadrants, there's a mnemonic that you can use. Okay, it's going to be a lot of mnemonics. I'm sorry, okay, but you have to just hear me out, and then pick up a few critical gems here. Okay, and then after that, go for a course or look at the YouTube again. Okay, so each of these quadrants will have a mnemonic. So we'll go to the empathy quadrant first. The mnemonic for empathy is empathy. Okay, I made it as rememberable as possible, although there's many things to it, right? Okay, so there's a few things that I'll stress that is most important, right? Okay, so these the expression of empathy, there are 7 strategies. So not all of us naturally is able to convey empathy, right? Empathy is the ability to put yourself in another person's shoes and feel what the other person is going through. So some of us are more cognitive talented. Some of us are more emotively talented. So the more cognitive talented one will come out with this mnemonic to help the cognitive talented one express empathy, right? So that's why it is in this manner, okay? So number 1, emotion spotting. So when a person that speaks to you is frustrated, then you just have to recognize that emotion and stay it out. So, so-and-so, I can see that you're very upset. Enough already. So-and-so, I can sense that you're very uncomfortable about what I've just said, So why do you need to do that? Because a person wants to feel heard and understood. So if you're able to state, to identify, or to put a label to the emotion midway through that conversation, that person would know that you actually understood his feelings. Now, second thing, also a no-brainer, is to mirror a person's thoughts in your own words. So a person that's in front of you may say a lot of things, I love my mother very much. I can't, really let go of her. I know it may not help her. I know the treatment is invasive. I know there are a lot of consequences, but I cannot bear for her to leave me. So the person speaking to you may give you a whole mass of information. Then what you need to do is to process it and then repeat it verbatim, but in your own language. So I might say, Miss So-and-so, I can fully understand what you're trying to say to me. Your mom sounds like someone that's very precious to you in your life, and you cannot bear having any thoughts of her leaving you. And therefore, although you know that this treatment that I've mentioned is going to cause her a lot of pain and distress, you would still want us to go through it. So it's the same way, just packaged differently. But what is the benefit of doing this? The benefit of doing this is that the other party actually feels and know that actually whatever that they said was actually processed by you. It wasn't just fleeting thoughts that go through your mind as a daydream, but the fact that you truly mattered, you truly put in the effort to try to understand and hear what he or she is saying. Now, the third strategy here is very important, pausing and listening. Many a times, we all have an agenda when we go into the family conference. We all want to try and convince them to come our way, to do it our way. But many a times when family members are very emotionally charged, they need to ventilate. If they are not given a chance to ventilate, they will not feel heard, H-E-A-R-D. And therefore, sometimes we just have to keep quiet and let them ventilate. After a while, after they speak all that they want, they may tear or they may pause. And that's when you pass them the tissue paper that we usually teach, right? And then after that, the emotions start to reconnect with tearing, and that's when good things start to happen, right? So pausing and listening is important. Another strategy is affirming positive efforts. So you may want to tell the family member, I know that you're trying very hard for your mother. You love her and you want everything that can be done, to be done for her. I fully respect that. And I think that's very filial of you. I can truly feel your deep love for your mother. So that's affirming positive efforts. It helps to convey that feeling that actually I'm an ally. I'm on your side. I'm not trying to, be the enemy here and try to take your mother away from you. I know that you're trying your best. And then, of course, the very classical teaching of keeping things open-ended. Oh, that's something interesting that you just told me, I can sense that, you have a lot more to share, something deeper, is coming out from this conversation. Can you share with me more? And then some of them would then talk more to you. Now, always hold your judgment. Don't always label them as full of nonsense, or we call FON family members. Don't always hold certain judgment. Oh, this is the bipolar family member, and then put a label to it, right? always hold your judgment, okay? And the other H here is to provide hope, right? For every bad news that you give, always provide some hope. Now, how will you do it? We may then say that, I'm afraid I have some bad news to tell you, your loved one is having a very serious condition. Life expectancy is limited. It's quite terminal, but please don't worry. We'll try our very best to keep her comfortable. There are good medications that are available. We are very certain that these symptoms can be contained and controlled so that she would not need to suffer. So you always balance bad news with a bit of hope, bad news with a bit of hope, right? And finally, like how I'm speaking to you now, watch your pace, watch your tone, right? Always sit upright, okay? And lean forward a little bit so that they feel that you're attentively listening to their conversation. So body posture and all that also is important. Okay, I've been through all this, so I'm going to skip this for now. Okay. Now, of all these things that we have mentioned about empathy, which are the 2 things to remember if you forget all 7? The 2 things to remember is emotion spotting and mirroring of thoughts, the first 2 alphabet. If you use these 2 strategies well, you'll go a very long way. And it's really a no-brainer. You just have to identify and state the emotion and then repeat what they say to you in your own language, in your own fashion, and they will feel understood and heard already, right? Okay. Now, again, for people that are more cognitively inclined and we really cannot feel what a family member is going through, we then teach this next quadrant of engaging. Engaging in the sense that we are bridging between you as a healthcare provider and the family member or the patient in front of you. Now, this is something that Dr. Ng has taught me many years back, and it's something that I greatly value and we use in our clinical work very often. And this is called the Maslow hierarchy of needs, right? Okay, every one of us are very similar. We all have all these needs. And the base of the parent need needs to be fulfilled before we can talk about the higher strata of needs. So for example, if you're in a war-torn state like Ukraine, whereby you've got no air, no water, no food, no shelter, then you don't talk about being loved and loving others as a need. You just want to survive, right? Now, if let's say you've got food and water, then you worry about your health, your employment, your money. And then you got money and basic enough for you to live. Then you talk about, I want a relationship whereby I want to feel loved. And also, people often forget that there's a need in all of us to love another individual, right? Precisely because we cannot love an individual, that love is being threatened by a terminal illness. We get very aggrieved and we are emotionally disturbed. And then beyond that, there is this self-esteem and sense of dignity. And some people may then want to fulfill their talents to the utmost, what we call self-actualization. Such self-actualization may not be a spiritual endeavor. It may be also a fulfillment at work or in some form of social domain. Now, recalling that everyone has their needs, we then go on to this strategy called the 3 cons of conversation. When we speak to family members, we are trying to dig deeper and deeper into these 3 Cs. We may start off by first trying to understand conceptual things or bring across conceptual ideas. What is the illness? How severe it is? What are the treatment options? This is what we all do very well in because this is what we are trained to do. It's factual. There's nothing to do with emotions, and therefore it's simple to do. And when we sometimes try to go into a conversation because it's something that we know very well, we try to rush and just download all this information across, hoping that that will end the conversation there. But actually, if you don't go on and dig deeper, like what I've mentioned, the other side will not feel heard and understood. And without trust, they will not want to proceed with whatever recommendation that you have for them. So that's why you have to dig further beyond that factual information to find out what is the person's concern. How is that particular disease or treatment going to impact the individual on a physical, functional, or social front, right? For example, chemotherapy may make a person lose their hair, and for ladies, that can be devastating, especially for younger ladies, right? Or a certain treatment or a surgery may make a person lose the ability to self-care, and she lives alone, or she lives with another person who is dependent on her for care. And then, the person may not want treatment. Or it may impact social wellness. A person may value a lot of interaction with family members or plays a very important role in the family as a caregiver, like the grandmother to young children, right? Young infants. And she's very worried that, if she could not fulfill that role, if let's say, she develops an infection and she was worried about spreading the infection to the young kids, or she may have discharges coming from wound that may then be unhygienic, and she cannot fulfill her role as a grandmother that gives her a sense of fulfillment and importance and meaning, then she may not want treatment, right? And then after that, we have to go and dig deeper. Now, we may be able to elicit all these concerns, but how is it different for this particular individual, right? For example, every individual may then say that, oh, I want to live as much as possible as an independent person. I don't want my family member to view me as a burden. I don't want to financially drain my family members, and all that. But for this particular patient, it may be different because, this particular person may be the sole breadwinner for a whole big family, right? Or this particular person may not want a life-saving amputation because of certain religious beliefs, right? Or this particular person feels that, Western medicine is crap, and by willpower alone, and through willpower alone, I've survived so many crises in my life. I don't need Western medicine. So for this particular patient, why is it that he feels this way or perceives things this way is important. So that's why in this quadrant, during that conversational process, we're trying to dig deeper and deeper into the psyche so that we understand the person, not as just a person, but as an individual, as a friend, as a person that you can relate to. And that is how you establish rapport. Right? Okay, I'm going to give a very quick summary to the other two quadrants because of the interest of time. Okay. Now, we have talked about the emotive part of that quadrant, the empathy part and the engaging part. And then the factual part becomes much easier after that, So if let's say there's rapport and there's trust, what we need to do then is to tell the patient and the family member, okay, so this is the problem. You have a cancer, the severity is stage 4, we have got a few options, good and bad. This option gives you less side effects, but poorer survival, blah, blah, blah. You may lose your hair, you may have diarrhea, okay? And then help them weigh. Based on what you told me about your family background, based on what you tell me about what's important to you, based on what you tell me about your roles in the family and the community that you value, do you think this option will be most suitable for you? And then after that, modulate the expectations and tell them, now, if you choose this option, the best case scenario is this, the worst case scenario is this. Most people suffer in between, experience the in between. And therefore, you have to modulate your own expectations. And then don't worry, we will journey with you and we'll mitigate these problems along the way. And then you think about what resources to activate. This may be the social worker, this may be peer support group, it may be factual information you can give to them online on a brochure. So different healthcare settings, different resources to activate. And finally, in this quadrant, what we're trying to do here is really, based on the previous quadrant, we already identified who is this person, what are the important values for this person, what this person values that gives them meaning in life, and how these things influence their choices. And then finally, based on these values, what is the best option that this patient would want, how can we then help them modulate their expectation, and how can we help them journey through this treatment option, right? Okay, so I'm going to just skip this. Okay, these are some of the common resources that will teach our residents. Okay, right. But again, in different healthcare settings, the resources can be different. Now, finally, that final quadrant, this is a quadrant purely for you to summarize the whole conversation, right? You can picture it this way, in that last 5 minutes of your conversation, you will tell them that we've talked a lot about, your condition, your options. So let me do a summary for you. I know that as a grandmother, it is important that you remain independent so that you can take care of your grandchildren. You do not want to be a burden to your family member, and you're concerned about your family finances. Now, based on this, we have chose this treatment that has less impact on your function, less toxic, but of course, we know the likelihood of success is poorer. The worst case scenario is this, the best case scenario is this. Now, in order for us to achieve this treatment option, these goals, okay, you have to do this for me. You have to come back every few weeks to meet me. I'll give you the medication with some blood test to check, and then we'll try this treatment. Sometimes we'll do what we call a limited trial treatment. If it works good, we continue. If it doesn't work, let's look at other options again. And then, we'll sit down, we'll summarize, and then we'll reschedule the visit. So these are the 4 quadrants. They will cover both the emotive part of the brain as well as the factual part of the brain. Okay, sorry, I have to sell a bit of goyo here, not intentionally, because we covered so much grounds today, both on communication, on ethics. Actually, all this content matter is actually being taught in a course that TELC is giving, okay, what we call the clear course. Communication, law, ethics, and professional regulations. The idea is to convey clearly, to the participants about some of these ethical and legal aspects of end-of-life care. Now, these 4 quadrants that we have mentioned being applied in different scenarios is also being detailed in this book that we recently published. Okay, I'm not asking you to buy it. I'm just going to take a look. Okay. Okay, so no goyo to sell. So that's my last slide. I don't know whether I've overshot time, and then we'll go on to Q&A.
Thank you, Han Yee, for an excellent lecture. I was like so inspired, so moved, and I laughed a little bit because of some familiar kind of scenes that triggered, in my mind. We have got 5 questions from the floor. Let's just tackle them. Okay, maybe I'll just ask all the questions, and Han, you can take liberty to decide how to, answer them. So the first question is from Richmond Manabat. How long are most people in palliative care for? And then the second question is related to person with dementia with BPSD, behavioral issues, who choose not to take medication that will assist with behavioral management. Family asks doctor and healthcare professional whether they can mix the medication in the patient's food. How should we approach this question? The third one is by Dr. Louis. I must say, with mask on, it's more difficult to do emotional spotting. Any tips? And how to spot emotions in family members who are silent or put up a wall. And the last question is, the second last. The last question is about where to buy a hard copy of the book. Okay, the last question is, a patient with advanced dementia and severe food refusal has been on NG for some time. Patient has remained stable for some time, shows no signs that he disliked the NGT. His weight has improved and stabilized. If the main spokesperson or legal donee suddenly says that he doesn't want the patient to be on NG2 anymore, to be back on hand feeding, but as a medical professional, you know that patient will definitely deteriorate quickly due to malnutrition. What's the approach for this? So it looks like some questions are very similar, some are slightly different. So Han Yee, would you like to address all the questions together?
I'll quickly answer all of them. So how long are most people in palliative care? Last time, maybe about a decade ago, we usually receive referrals when a person in the last 6 months or last 3 months, or when they're imminently dying. Nowadays, palliative care has moved upstream to take care of patients in much earlier stages of disease, as well as in organ failure whereby their life expectancy can be in years. So there's actually these 2 extremes that we're dealing with now, patients who are imminently dying, as well as patients who are newly diagnosed with a life-limiting illness, but with a much longer runway in terms of years. Because the belief is that the approach of palliative care, being comprehensively addressing physical, psychological, social, functional, and spiritual needs, will benefit all these patients throughout their entire trajectory from the time point of diagnosis of an advanced illness. The second question deals with a patient with dementia and BPSD and chooses not to take medication. Now, there's a specific term for this doping or medication. That term just escapes me for now, right? Generally, we would say that we shouldn't be doping a person who has got capacity, because we should take informed consent, at least verbally, right? Before we put a medicine, we shouldn't be giving a medicine to a person who has capacity, not telling him or her about the risk and benefit of that treatment. But for a person that does not have capacity, then giving that medication, yes, I think I see Kai Ping here telling me it's covert administration. Thank you, the word came to mind now. So covert administration actually does not apply here when a person does not have capacity. Now, that doesn't mean that we can just vagrantly just, dope our patients. As much as possible, we try to engage and to tell them. But if truly this is a person with very limited cognitive faculties, and we are giving it in the best interest of the patient to facilitate care, nursing, and all that, then it's okay. We do not truly need to take informed consent for everything. Okay. Now, the third question is this, how to spot emotions with a mask on. Yeah, I mean, facial expression is only one way in which we can spot emotions. The person's posture, the person's volume of voice, the person's emotions in that voice, the person's, other things, whether he's tearing and all that. Person just stay very silent when you talk about certain sensitive topic. sudden tensing of postures will all tell you things. In fact, other things that I'll share with you is, how a person sits, where a person sits in a family conference will tell you things as well. A certain person may stay very far apart from other family members, and that will show the dynamics very clearly, or the person may be right in front of you speaking to you, whereas the rest of the family are like, taking a back seat, quiet, very docile, don't dare to be engaged. Then you notice it's the alpha male or female in the family that's, making decisions, So in that case, you already know, what is the dynamics and what is the emotion just by pure observation alone. And of course, hearing the fluctuations and the intuit and the nuances of the language, right? Sorry, my mouse just suddenly went without battery. What's the fourth question?
Okay, it's actually related to people without capacity. It's like NG tube, that person has been on NG tube very well, but suddenly a donee say, please remove NG tube.
Yeah. So this is a difficult question. It would have been something clear-cut in the US or the UK. Because if a person is in a persistently vegetative state or a permanent comatose state, both of these are medical diagnoses to be made with specific criteria in mind. Then there are legal precedences whereby the court will have said it's okay to withdraw, and particularly if a person has previously had some documentation, some conversation of advance directive to say, I don't want it. Now in Singapore, we never had such a case going to court. Right? And actually, if you look at our Advanced Medical Directive Act, the AMD Act itself, it says that you can refuse all these extraordinary life-sustaining treatment, but palliative care and food and water is excluded from the AMD. Right? Of course, it applies to persons who has an AMD, but it also tells you the legal stance that at that point in time when it was written up and it has not been amended by Parliament or by the judge, right? That food and water remains a very sensitive item culturally. So for a person who does not have an acute critical illness, but has got a very impairing cognitive process, right? Such as, for example, like advanced motor neuron disease or advanced dementia, such that they cannot communicate or understand and interact, generally we will be rather uncomfortable removing food and water or nutrition. Now, why would then overseas countries say that it is actually okay to withdraw? Now, overseas, this is how they look at it, which makes sense, okay? Which is that when you feed a person nutrition or fluid through the nasogastric tube, it is very similar to us injecting antibiotics through an intravenous cannula into your vein. Both involves plastic tubes that are not natural to your body. Both involves chemicals that are artificially concocted and then delivered into you without you actually partaking it actively. So that is why in UK and US, many of these court cases, it'll be argued that these Ensure, Glucina, Nutrition, and all that that's going through a feeding tube is no different from any medical therapeutics that is otherwise given to the patient. And if you can withhold antibiotics from a patient because of the fact that we don't think it will overall benefit a person from advanced dementia, then by that same logic, you can withhold NG tube feeding because it's something artificial. But you can see that, there's this difference between the Singapore stance and the UK, US stance, precisely because we are two different societies, make up of very different belief system, very different religious views. In the US, individual states may have different religious convictions. And therefore, all these laws and regulations are enacted in such a way that reflects the societal values. So at this moment in time, it has not been tested yet. And therefore, we have not been trying to actively remove NG tube feeding from patients with advanced dementia purely because, a family member insists on doing it. Yeah. And often this problem arises when you have a returning overseas family member who is familiar with another set of healthcare laws. And to explain to them that unfortunately, we can't carry it out. We understand the principles behind the arguments, but we can't carry it out because we do not know whether this is legal. And if need to, we have to go to court to clarify it. Now that makes it difficult, right? And the last one is where to buy the book. Yeah, the book is available, I think, through that final slide that you can.
You can share the slide again.
Okay, sure.
The QR code, yeah.
And the QR code, and it's also available at Research Book Asia. I think got a few branches around. Yeah. Okay. Yep. Okay. I didn't prepare this slide specifically for this talk. It was prepared for, I think, Singapore Palliative Care Conference sometime back.
It's okay. So yeah, thanks Han Yee for that. It reminds me of that Terry Schiavo case, right? That
Yes.
in America, there was a lot of battle in the court about whether to remove the PEG tube by the family. And yeah, so yeah, there's law is always in reference to the local culture, lah, you know, so whether to repeal the AMD or not, so depends on okay, the next PM. Okay, so actually I think we are overshot. Actually, we scheduled for 1 hour, so we got but it was a very rich discussion. I think it's very practical, especially for clinicians. I mean, we target this for the home medical doctors. Many of them are here, but there are also many nurses, many social workers, many allied health who are very interested in this particular topic, especially from an expert like yourself. So thanks so much, Han Yee. So with that, maybe I'd like to invite Dr. Tiong Christina, the CEO of HNF, to give us a closing, because it's the last of our webinar series. Yeah.
Okay, hi, thank you everybody. So I just wanted to invite you to our next highlight of this CME series that will culminate on the 11th of November at the MND auditorium. It's also available online. It's a half-day webinar seminar that we will be inviting Dr. Diane Myers from the US, as well as a very esteemed panel that includes Dr. Neo and Dr. Angel Lee and many speakers who are experts in the area of palliative care and have launched many programs that are being held in the community to support frail elders in their palliative care process. So please come to our next webinar, which is Through Sickness and in Health, and register for it. We will be sending it to you. And that leaves me to thank once again Dr. Ng for leading this very exciting series. We will be continuing to do this for a couple of other topics. The next one will likely be on caregiver support. And also much thanks once again to Dr. Neo and his wonderful department at Tan Tock Seng Hospital. So thank you everyone for attending and supporting and encouraging us in this journey. All the best.
Okay, thanks, Christina, and thanks, Han Yee, and thanks everybody for participating. So we shall end this webinar series now. So thank you. Yeah. Bye-bye.